Okay, so guys, I'm sitting here with Dr. Richard Gelman, and he is a board certified orthopedic surgeon, and he did my first and my second ankle surgeries. The first one to put all the hardware in, the second one to take it all out, well, most of it. And before I let Dr. Gelman tell you guys about himself, I need to tell you how I got to him, which if you've read the blog, you already know, but I broke my ankle. The guy in the ER who saw me, he was my intake doctor, he said, you're good, like you probably won't need surgery, and sent me home with a cast. And then a few days later, I went to the guy that he referred me to, which was a different orthopedic surgeon. And he was like, yeah, this is not good. Like, you're gonna need surgery. We're gonna be like right in there next to a really important nerve, but don't worry, like we'll do our best not to hit it and it'll be fine. And like, yes, you need surgery. And he scheduled it for like a few days later. And I felt like really gross about him. And if you already read the blog, you know this, but I was just like, this just doesn't feel right. And I was freaking out because we're all freaking out. And my parents were like, dude, you have to go get a second opinion. So they did some digging, and it was like a friend of a friend of a friend knew Dr. Gelman. And so they got me into his office the next day. And Dr. Gelman did all kinds of other scans, and he could probably talk about what they are and why he did them. But a bunch of different scans besides just like the x-ray that I got from the previous two doctors. And then he like calmed my mind and was like, it's going to be okay. And then we did surgery. I think it was like the next day or a few days later. My first surgery ever. So this is the man who did it. And I'm so excited to interview you. Welcome. I'm so excited you're here. And Dr. Gelman and I have stayed in touch over the years because he's just super cool. So he agreed to chat with me. And the first question I have for you is just like, tell people who you are, how you got here, like, what do you do? Tell us all.
Good afternoon. My name is Richard Gelman. So I'm an orthopedic surgeon, and then I also did subspecialty training in foot and ankle for a year, and then also about a half a year for trauma. So I've been doing a lot of work on people that are injured, breaking their ankles and lower extremities for the last 20 years at a trauma center here in Portland. And so that's pretty much who I am.
Nice. Okay, so like I said, when I made it to you, I had like been through a few guys already that I didn't feel awesome about. So for me, it was a really big learning to get a second opinion if you feel like off in any way. Can you share, like, once somebody breaks their ankle, what are the things along the way that they can be doing before they actually have the ankle surgery to like advocate for themselves and make sure they're either talking to the right people or getting the right scans or getting the right surgery? Or like, how do we advocate for ourselves in a system that doesn't always advocate for us?
I think a clear understanding of the fracture, that's, from our training, we always think very anatomically. And if people can understand that, most ankle fractures occur from a twisting injury, there's a common way for us to look at and describe an x-ray and know how you broke your ankle. And so when you talk to an orthopedic surgeon, they've seen this hundreds of times, and they're going to look at your x-ray and they're going to say, oh, we see that you broke the outer bone, the lateral malleolus at this level. We see that you did or didn't break the little bone on the inside, the medial malleolus, or in your case, you broke both the little bone on the outside, the inside, and off the back. And each fracture pattern has with it a different approach for the surgery, the incisions, the type of hardware that goes in, and then the general recovery. One thing that's important is all that information should be communicated with you at the first visit with the orthopedic surgeon. Okay, so you, Mihal, went through the standard path. One visit to the ER to see an ER doctor. That's not an orthopedic surgeon. They're going to always generally err on being conservative, not be too informational, have too much information about whether you need surgery or not, but should cover themselves so you don't injure yourself further before you see a subspecialist. So they're going to err on splinting you and immobilizing the ankle and on keeping you non-weight bearing until you see the specialist. And then when you see the specialist, as I've said earlier, you should have a clear understanding of your injury, and then a clear understanding of the surgery itself, like what's going to be fixed and how, and then a clear understanding of the early rehab in the first 6 to 12 weeks. Okay. I mean, when we have injuries to our bodies that have enough energy to fracture the bones, and especially if they require surgery, we have to understand that a full recovery may take up to 2 years in one person, and it may be as soon as 6 weeks, in another, and they can both be fractures. Okay. So I would say those are the crucial things to advocate for. And if you're not getting that information after you see the orthopedic surgeon, then yes, I would look for a second opinion. And sometimes even during the stage of the first visit and seeking a second opinion, you might get enough information on your own that you don't even have to go.
Right.
You know, like maybe you thought the guy was good, but he went through it a little too quick, and you could go back and have a discussion over the phone with his PA and say, hey, I didn't understand. Or even better, they find, this website, and a lot of that information is answered, and they learn how to be both an advocate for themselves early on, before the surgery is, and then they get all this other great information for the recovery period.
That's awesome. And I like the part, I didn't seek this out necessarily from the first guy that I went to before you, but like understanding what the first few weeks of like rehabilitating yourself looks like, because that is, I know that for people who break their ankle, they're like, oh my God, what's next? When do I get to start walking again? Like, what does this look like? And that journey, whether it's just a few weeks or it's a few months, is like so hard to see it and understand it. And so having somebody who you can have that conversation with does feel really important.
Yeah.
So, okay. So now I've had the surgery. I'm done with that part. You're sending me home, whether I stayed the night in the hospital or I'm leaving that day. Like, what, knowing that everybody has a different healing schedule and a different experience, what are some of the most common things that that people go through in those first like couple days or couple weeks post-op that is like normal and fine and expected? And like, what can we brace ourselves for?
A lot of pain. And then if you don't have a lot of pain, then awesome. Then we're really happy for you. But it's important to put in your mind that you might have a lot of pain. So that, and we can expand more on treatment later.
We'll come back there.
Yeah. Okay. Swelling. That you feel like there's nothing you can do in the first few days to really get this really throbby swelling down. You only know that it's not horrible when you then get up to go to the bathroom, and then it really throbs. Okay. Yeah. However, don't be complacent about your elevation, and keep it down so you don't get that transitional pain, because what you're doing is causing more blood to permanently pool, which increases your risk of infection and will also lead to a much longer period of prolonged swelling in your recovery. I mean, infection is huge risk. That's not life-threatening, but certainly limb discomfort, potential second surgery to clean out infection, a big hassle and a lot of pain. So elevation.
Keep elevating.
keep elevating and address that swelling. So those are the two ones in the first 3 days. Other things that you will discuss further, like constipation, they're a pain, but they're very manageable
Let's
and
talk
they're
about
very, yeah,
constipation. I didn't poop for 6 days after surgery.
yeah. So everyone's a little different depending
If
on,
you go to my tips and tricks page, I have a bunch of things that will help you poop, which I didn't have back in the day because I didn't know about them, but now I do. So, okay. So make sure you keep pooping. That's one. We also have recipes for pooping. All right. What's another one?
um, really it's using how much you're using your narcotics, because that's the most frequent reason to get a call. And it's really hard to refill narcotic pain medications on the weekends. So, if you are running low, make sure to contact your doctor's office on a Monday through Thursday, to make that not a big deal if you need refill. We certainly in the United States have had an epidemic of narcotic overdoses. And so we really try to get our patients off the narcotics by 10 days after surgery. It used to be 6 weeks, then 4, then 2. And now, really, I'd like to get people off of narcotics by 10 days. And that's supported by the literature, our medical literature, as well as just patients feeling better.
So, so if I'm like in pain, but I think I could like do fine with not taking the full dose of whatever narcotic I'm on. Like, what do you recommend? Do I slow that down and add in some ibuprofen or something else? Or like, what's a good balance so to not like over index on the narcotics?
Right. So you want to make sure you're using all the medications that are non-narcotic first as a way to be a baseline. And there's no interaction between Tylenol and Motrin, or Tylenol and Aleve, or Naproxen. All these are different anti-inflammatory medications. So our recommendation is you get on a baseline of both Tylenol and the anti-inflammatory. And then think of it like this, like the food pyramid, right? Your Tylenol and your ibuprofen you can think of as your fruits and vegetables. Okay.
That's like the base. We want
Yes, your base. They're the things that are safe to take. And for the period that you're really going to need them, 24 hours a day is very short. Now, you don't want to overdose on either of them because you can get ulcer problems with too much anti-inflammatory, or liver problems with too much Tylenol. So you have to follow the recommendations, which are up to 3 grams of Tylenol per day, or for ibuprofen, if you can tolerate that, anti-inflammatories, it's about 600 milligrams every 6 hours with food. So those are your base. And then whatever narcotic you're prescribed, there's usually like 1 to 2 tabs. If it's oxycodone, it's 1 to 3 tabs if you're a larger person. So don't just take 3 every 3 hours, because 1 to 3 tablets every 3 hours PRN means as needed. So maybe in the first day you have to take 2 doses of 3 tablets, in the first 6 to 8 hours. But then very quickly after that, you spread out the time frame so that it's not every 3 hours, it's every 5 or 6 or 8. And certainly by the time 10 days goes around, you should be down to like 1 tablet in the evening, or 1 in the morning and 1 in the evening, so you can then stop fully.
that makes a lot of sense. And for those of us like me who are very, very sensitive, you can also go, for those of you who don't know, you can go and buy these little pill cutters like at any pharmacy or whatever, and you just like pop it into a little thing and go, and it cuts the pill right in half. And so I was even at a point at some point, I don't even remember what, but where I was taking like halves and quarters of pills because I didn't feel like fully ready to completely just stop. But I wanted to get over those narcotics because they made me feel so bad as soon as possible. And so I was like taking the teeniest little dose.
One thing I will interject here is that Americans got used to taking a lot of narcotic medication, and it was found to be driven by the pharmaceutical industry. So, in a very sophisticated way, just remember that high use of narcotics or dependence on those is no different than being addicted to heroin, really. And I'm sorry to say it, and it probably like certainly there are cases of people being in chronic pain that need to take narcotics, but for thank God for the majority of us that don't have severe chronic pain, you know, this is temporary and our bodies are made to address these with endorphins. And then please, for your ankle surgery, elevation and icing. Okay. We haven't mentioned icing, but even when you have a splint on, you can ice around the knee and that will cool the blood going out to the ankle. So realize these surgeries are not treated with narcotics anywhere else in the world, only in the United States.
Wow.
Okay, even in Europe, you know, the trend has really gone away from narcotics, and so they'll have a few tabs, but nothing. The all of the oxycodone is that's sold in the world is pretty much just in the United States. So
Okay. So that's great. So keep elevating. And I have a elevation pillow linked in my tips and tricks so you can make it easy on yourself. I did not have that, and so I just stacked up a bunch of couch pillows, which was very cumbersome. Also icing your knee when the splint is still on, and then icing your ankle once it comes off. And I also link my favorite ice pack, the little blue guys that you just pop in the freezer. Like, don't cut it for the amount of icing you're going to have to do. You need like real deal ice pack. So I think it's a wise investment. Can you just talk really quickly? You touched on it for a second, but I get a lot of questions about this. Is that feeling of when you're elevating and then you stand up, and when you're covered with the splint, you can't see it, but once it comes off, you see that your foot turns like bluish purple. What's the deal there, and why does it change once you start weight bearing?
yeah, and this we are jumping ahead a little bit from the early post-op, but I think I think it's fine to talk about it here. People, you'll remember, because it is a similar phenomena. It's blood pooling, okay? This is not a lack of circulation, okay? This is about venous return. A lack of circulation is blood going from your heart with oxygen down to your foot.
Mm.
That a blockage there is a lack of circulation. The return of venous blood, okay? Remember the basics. Blood with oxygen goes out of the left side of your heart, goes down into your extremities, and then it goes out of this venous plexus where the vessels are so small you can't see them, into the tissue, okay? Where the tissue is the muscle, the bone, and the skin. And then there's two ways to get that blood, once the oxygen is out of it, back to the right side of your heart, okay? One is elevating it. And so gravity will bring it back to your heart because the veins have valves, okay? Where once it travels upward, it won't flow back because there's a valve in the vein, okay? Now, the initiation of that in normal humans is walking. When we step down on the ground, the tissue on the bottom of our feet, the skin, and then under that, the muscle, okay, you push down and it starts this process of bringing the blood from the foot up into the little blood vessels, and eventually they get into the bigger blood vessels and bigger until they're in the vena cava and it's going into the right side of your heart. Then out to your lungs, get rid of the carbon dioxide, bring in the good oxygen, and then that cycle starts over. So basically, when you're non-weight bearing, the only thing you have in your favor is elevation. You're not getting all that advantage of that pump mechanism. And that's why you get this swelling redness in your foot and ankle areas. And then there are other tissues like the lymph tissue that runs through your skin and fat, and that drains, well, it's basically fluid in a normal manner when you're walking around, but that gets very like flooded and stays out in that tissue even, while you're non-weight bearing. But then, as you know, it takes months and months to get rid of all that swelling. Well, that's what's occurring, is this chronic swelling within the tissue that's more covered by lymph and a little bit less by blood flow. Well, that lymph fluid is very slow, and that's why they have specialists. They have these lymphedema specialists that provide these wraps that go off and on the leg, multiple times today to literally pump that out of the tissue. Most people don't require that, right? What we do, and what you link to in your site are, compression socks. And now they're so common, you can get them for $5 at Walmart,
Right.
So they're not going to be the same quality maybe, but they're, for the average person, going with like starting lighter first, that's more comfortable and easier to get on. And then you can go to more sophisticated, more compression if that's not taking care of it.
And also, for those of you watching, if you're trying to put on a compression sock and trying to take off a compression sock and your ankle and foot are still really tender, there are YouTube videos of people who have spent time telling you how to put on and take off a compression sock. But basically, it involves rolling the whole thing up until it's basically a little hat on your toes, and then slowly bringing it up your leg. And I'm not going to create my own video because it already exists out there. But just so you know, if you're struggling to get on your own compression sock, there are videos out there to help you.
You can also talk to your grandmothers, because they were the ones that had to put on pantyhose back in the day.
All right. So one more question sort of around that initial healing period. I, like most, I was like, every little thing made me freak out, and I was Googling constantly. I was most concerned with like blood clots irrationally. I don't know why, but that's just what sort of like stuck in my mind as the most scary thing. When is generally like a good indication in those first few days or maybe week or two that like you should call the doctor? Like, what should we be really worried about?
Really, it's just one. It's like a lot of increasing pain around the incisional areas, and that would be between like 3 to 10 days after surgery. That's the peak time when you could get a wound infection. You're not going to get a wound infection in the first 3 days, and that's when you have the majority of your pain. So when you see that, like you have this post-op pain, then it drops down, then you start getting increasing pain, really just around the incisions. That is a definite, you should call your doctor. The risk of blood clots in ankle surgery is low, okay? And there may be small blood clots in the superficial veins below the knee, which are common in the regular population, and then they can be picked up if people have like an Achilles strain or a muscle strain, an ankle fracture. Those are non-threatening superficial DVT below the knee, and I just keep people on aspirin. So I've been recommending aspirin only, like a baby aspirin or a 325. It doesn't matter, once a day, and it's really just sort of, because they do a little bit of platelet desegregate. They sort of thin out your platelet function a little bit, and the reason is that there really is not a connection between an ankle fracture and anything that is going to lead to a pulmonary embolus. There are good studies out there that show, whether you're on anticoagulation or not, the incidence of something life-threatening like a pulmonary embolus is identical. So I know that's a long-winded answer. You really don't need to worry about DVT with an ankle fracture.
DVT is the clot.
Sorry, DVT is deep vein thrombosis. That's one in your leg.
Yeah. Okay. I was so worried about it. I obsessed. Okay. So my next question for you. Now we've gotten the cast removed and you're like, okay, oh, what?
Right. Let me just say there's a cast where it's like rigid fiberglass, and there's a splint, which we wrap on and has the ACE bandage.
Is that what we had
Yeah.
after the surgery?
Yeah. So it's just important people to know it'd be highly unlikely your doctor would put you in a cast after ankle surgery because the hardware is holding the bone.
Got it.
The device put on your leg after surgery is to protect the incisions with nice padding around it, in
Yeah.
which case it's a splint because you can unwrap it in the office and remove it from the leg without a saw. Okay.
And the cast though, I had a cast, I think at the beginning then, like right, like in the ER, because I have a picture of myself in a cast.
No, it was a splint as well. They actually don't know how to put casts on in the ER. Because
Oh,
what you saw an ED physician, you saw an emergency department physician. It's an MD. They do not cast, they put on splints. Now, the type of splint varies, but it was a splint.
okay.
Yeah.
All right. So the splint comes off, like we go back to our orthopedic surgeon for a
Your
consult.
first post-op visit.
Yeah, and
Yep.
you're like, okay, it's looking good. It's doing what it's supposed to do. When do you say you're going to do physical therapy? What are you looking for to say, okay, it's time? And then if not, if you look at the ankle and you're like, there's something else that's needed, like what are other courses of treatment at that point?
Right. So the first post-op visit, you have to tell people, usually you'll get your stitches out if you have stitches, okay? Or some surgeons will use staples, and other surgeons will close the skin with something that dissolves under the skin, and you'll just get a wound check. But that's the critical thing at your first visit when the splint comes off is, are your incisions healing okay?
Okay.
Then majority of people are put into removable fracture boots at 2 weeks now. There are some cases where you want to do extra protection where you put on a fiberglass cast,
Okay.
but the majority will go into fracture walkers. And that's so you can start doing immediate range of motion in your ankle at least several times a day without a physical therapist, okay, just on your own. And in my practice for an ankle fracture, unless there's some unique circumstance of the injury, I will usually wait and start formal physical therapy at 6 weeks after surgery when the people are well healed and they can absolutely be weight bearing. Okay. Now, depending on your type of fracture, I've let people start weight bearing as soon as 2 weeks after surgery in their fracture boots. If it's a stable pattern, which would be just a fracture of the outside bone or just a fracture of the outside and the inside bone, but no significant ligament injury. In your case, because it's on your blog there, you had to wait 7.5 weeks because you had a big fracture off the back that was large enough to affect the weight bearing on the surface of the joint.
Yeah.
So it will vary, and your surgeon should have a clear explanation beyond. That's what I do for everyone.
Hopefully.
Yeah.
So if the recommendation is like either starting to do some range of motion exercises at home or starting physical therapy like right away, what do you hope for your patients to get out of physical therapy? Like, what is the goal from your perspective, sending them there?
My goal is to meet the expectations of the patient. That's number one. So that better answers your question on who's going to go to physical therapy after an ankle fracture. And the reason is some people don't want to go to physical therapy and they really want to just do it on their own. And they always, if you have a trusting relationship, they'll say, if I can, if I can do that, is that okay? And other people, they really need physical therapy. They need the reassurance that it's okay to move. They need someone to physically watch them walking to make sure they're moving into even gait training. Sometimes if they're older, and I really just am going to be very worried they're not going to trust enough to walk on it. And I get that sense in the office.
Yeah.
But in between, there's an enormous gray area, and there are several determinants for physical therapy. One is, what does your insurance provide? You
Right.
know, I am not going to send someone to physical therapy that costs thousands of dollars if we can try to do it by patient education in the office, maybe YouTube videos, maybe things like we're trying to develop here, and they are doing okay.
Yeah.
Their recovery may be a little bit longer without that expertise of the therapist, but maybe they'll eventually get there. Okay. Um, then there are people that are very active. They've got, you know, decent insurance coverage. Okay. And they are able to go to a therapist and enjoy that interaction, and it gets them back much quicker. You know, we know that, you know, physical therapy is what you put into it.
Yeah.
And
What
so,
I loved about physical therapy is that I felt like for an hour a day, somebody else on this planet was as obsessed with my ankle and my foot as I was. And like everybody was caring in my life. Everybody wanted the best and wanted me to heal. And but like in that moment, we were both
yeah,
fully focused on nothing but my ankle. And that was for me, that was like the really reassuring, like, okay, we're both obsessing on this the same amount for a certain period of time. And that was really good for my healing.
yeah, yeah.
Yeah. Okay. So, and guys, if you haven't already watched the interview with a physical therapist, that's on my videos page too. So we're not going to go like super into physical therapy here, but there's a whole separate video for that. Okay. So hardware removal. This is the probably number one question I've gotten asked over the past 8 years. When should people get their hardware out? What are the ideal, like optimal cases to get it taken out? When do you totally recommend against getting it out? And yeah, I guess let's start there.
So for hardware removal, it never needs to come out. And if I look at all of my patients, 90% live with their ankle hardware. Okay. The reason is that if it doesn't bother you, it does involve real surgery to remove it. And any real surgery is going to cost, whether it's you or your insurance company or society or, you know, whomever, it's still $15,000. Okay. So I, as a physician, cannot with any good conscience recommend a procedure that is unnecessary.
Yeah.
That's what people should really understand, number one. Number two is, does it bother you? Really? Like, just because you can reach down and massage under your skin and feel a lump and know it's a screw, is that a functional bothering? You
Right.
know, doctor, it hurts when I do this. Well, then don't do that, right? So that's super important. I've got, you know, a couple screws in my knee from an ACL reconstruction. And yeah, that's when I rub them, I know what they are, you know, so what? If, on the other hand, because it's your ankle and you can't wear your regular work boots, or you're an avid skier, I'd say try to just get a heat relief over that one ski boot, as opposed to going in, like I said, costing the system $15,000 and yourself pain, okay? Because you have to go through the pain of hard removal. But if it's bothering you every day, sure, have it out, because the small pain of having it removed far outweighs living it with it for the rest of your life. Okay.
Yeah.
There are unrealistic expectations of hardware removal. And those would be, I'm going to get back a big range of motion.
Yep.
You may subjectively feel a little less stiff, but when we measure that range of motion, I've never seen that increase from a hardware removal, even if I've added on releasing the joint, resecting a little extra bone, you know, taking off a spur. People may feel a teeny bit better, but I've never seen it really improve their range of motion.
Yeah.
However,
I agree.
having worked with like the ballet community, you know, you'll see a ballet, you know, a principal dancer come in and their foot's already flexing, you know, 50 degrees downward into plantar flexion more than yours would ever dream of, because they've been doing this since they were babies, right? And that's part of the art, you know, to have like overly, you know, even that patient will say, my ankle feels stiff.
Right.
So there's stiffness that's subjective, how you feel, and there's stiffness that's objective, what we can measure. Okay. But if the stiffness that you feel goes away, then it's also, hey, that's worth it, right? Because your ankle feels more normal to you. So
Yeah.
that's sort of a long explanation about hardware removal. Certainly, if you've had an infection, God forbid, you have an infection, that would be a reason to take out hardware because infection can hide under the metal. That knock on wood is a very rare occasion, and that wouldn't be like something that your doctor would discuss and say, hey, maybe you want to do this. No, he'd say, we need to take you to the operating room to treat the infection. And that includes, it's safe to get the hardware out now, or we're going to just leave the hardware until it's healed, and then we may have to take it out later. So
Yeah.
there are certain indications. Those are very different from, hey, it's 6 months after surgery or a year after surgery, and now I'm thinking, hey, do I want to live with that hardware? That's what we're more talking about. The last one I'll mention is there are older populations where even if they feel the screws a little bit, or maybe it wears on, it prevents them from wearing certain shoes, I recommend leaving it in because usually these are osteoporotic fractures and you could re-break with a much higher chance in that population than in young people. Anyone in their 20s through their 60s or 50s, I would say for sure should just think of hardware removal as we previously discussed. Like, does it prevent shoe wear? Is it causing like consistent pain that you definitely are bothered with on a daily or weekly basis?
And it seems like there's also like a middle ground because I got 9 screws and 2 plates, and you basically took out all the hardware on the side that was really bothersome to me, and then you left 2 screws and 1 plate like along the back.
The
So
back, yeah.
it's also not necessarily all or nothing.
Correct. And the reason we didn't take the plate out of that was off the back of your tibia, it's an enormous surgical dissection compared to just taking out the one you could feel.
Right.
And I know for sure that the plate that I put on the back of your tibia, there's no way you can feel that.
Yeah. Yeah.
It's just covered up by too much muscle. There's no way you could push from any side to even get to that stuff. So in that case, you're causing more potential recovery
Right.
and absolutely not changing your pain symptoms or functional symptoms. So you should, hopefully, by the time you get to hardware removal stage, you're comfortable with your doctor that you trust them. But it is funny, I'll often get referrals in just because people felt rushed always on their initial treatment. And when it came to their hardware removal, they just wanted to go to someone who they got a second opinion.
Right.
So it's not uncommon, or people move, they come from out of state, or their insurance changes. There's various reasons that you may end up not getting your hardware removal done by your primary doc, but it's always better if you can, just because they know how they put it in.
Yeah. Yeah. And I mean, I was so happy to have mine out. Um I did, like, I had that screw in my ankle, and it really bothered me, and I felt also just so tight. And I agree with you, like getting the hardware out itself doesn't make you less tight, and it doesn't make you suddenly have more range of motion. But every time people ask me if I would recommend it, I'm always like, yes, because for me, I immediately felt sort of like less bothered in general. And that, whether it was mental or physical, that was a hurdle that helped me in my ongoing healing journey. So whether it was getting range of motion from physical therapy or from exercise or massage or whatever it was, I felt like having, and it was probably mental now that I'm saying it out loud, but having that hardware out of the side of my leg was like it felt like it opened up more space to like to get more space. And the surgery itself, and I talk about this on my blog, but it was nothing like the first one. That said, it can be undersold. Like if you go on Google and see what people are saying about it, people are like, oh yeah, it's nothing, it was super easy, da da da. But it's still surgery. It still takes days, if not weeks, to recover from. Not the same as the first one. Like it's not the same kind of recovery, but like do give yourself time to process and to heal and to, because it's not another surgery. It's definitely another surgery, and you will feel it. So it's not nothing, but in my experience, the payoff was like huge.
And I think that's something to further specify. In my mind, usually it's like a weekend recovery. Like if your hardware comes out on Friday, you're usually fine to go back to work on Monday, if you just do light work.
Yeah,
I
and
really stress people for 2 days after their hardware comes out, pretend like you got a bad cold. I'm not going to say the flu.
right.
And you want to really elevate like you did after your original injury. Even if it's overkill, so what? It means that your feet aren't swollen and you're not going to have pain, so you still want to ice and elevate for a couple of days after surgery. Don't think you're going to go back to work in 48 hours and stand for for 8 hours or something crazy like that.
And I still then continued to, I took a week off. I got it done on a Wednesday or a Thursday or something. And then I went back in the middle of the next week to work. And
Yeah.
I think if you can take a week off, that's beautiful. And then you get to really just like take your time with the healing. But I still, for a couple weeks after that, every day after work, I would come home and ice and elevate. And
Nice.
it's not like you're done and then you're elevating.
I think done is about 3 to 4 weeks.
Yeah.
That's what I tell people. Yeah, after 3 to 4 weeks, because for first 2 weeks, for example, say you were back to running or something, you cannot do that and not get a lot of swelling and risk getting an infection. And for a lot of people, giving up 2 weeks of running, if they're really passionate about it, that's a pain in the ass. So for them, a hardware removal is going to feel like a big setback, right? Or say you're a swimmer, if you have a hardware removal and an incision, you got to stay out of the pool for 10 days. Or if you're a cyclist, because we're in Portland, there's a lot of people that do all this stuff. Same thing, you can't get back on a bike and spin for an hour for, at least you shouldn't, in my mind, for at least a week. So that's what we mean by hardware removal, is not just like going in the doctor's office and having your stitches out.
Right. No. Anything else that we didn't cover, like that you get this question all the time from everyone that you just want to cover off here and now?
I do. I have to cover this one because the most common question that people ask me as soon as I describe they're going to have internal fixation, plates and screws, is, am I going to set off the metal detector at the airport? So I just want to throw it out there and say this: you will no longer set off the metal detector, but remember, when you're asking that question, the metal detector is the wand that goes over, or the smaller one that you walk through when you can't do the body scan.
Yeah.
So the metal detector will no longer go off, I heard, if it's metal under the skin. So that's number one. Two, you will see the metal on a body scan, right? Because they do an outline of your skeleton and anything dense. So if you got a phone, obviously a knife or a gun, it's going to show up on the body scan as that object. And so will the hardware in your ankle or your, parents' total knees or your total knee or hip. Okay. So that's the reality.
Yep.
Now that's what physically goes on at the airport. And the second thing is, no, you don't need to carry a card from your doctor, because how official is that card, right? You can't even use a driver's license pretty soon, right? You got to have your official ID pretty soon. So you think a little card, a paper card from your doctor's office that says I have hardware under my ankle is going to get you through TSA? No. So you don't need to request a card from your doctor.
Excellent. And I can
Okay.
validate that I had a lot of hardware in my ankle because I went on a plane with all of it on and nothing, no bells sounded. So it
Okay. So that is probably the most robust discussion on will you set off the metal detector, and you can, if it's not your burning question, the person that broke their ankle, it will be your parents or someone you know.
Well, thank you so much. This was super awesome. And I know that every person who has broken their ankle is always just dying to have, what is it? It's been like an hour long discussion with a board certified amazing orthopedic surgeon like yourself. So thank you for taking the time, and thank you guys for watching, and that's a wrap, baby.
Thanks.